everyone. Welcome back to Pulm Peeps. We're recording this episode in early December, and we just want to make sure we congratulate everyone who just finished their pulmonary and critical care boards. Finally behind you, only a lifetime of tests ahead of you. And we also want to congratulate everyone who just matched a fellowship. Christina, as an APD herself, also congrats with being done with recruitment. I'm sure it's a big sigh of relief. I hope you took a much-deserved vacation and are ready for our next Pulm Peeps Roundtable.
Thanks great to be back and really excited about this roundtable and have not had a vacation yet, but hopefully in the next couple of weeks. And again, I think just to all the programs out there and to all the trainees, I think everyone had a really great, successful match. So obviously excited about that. But so excited to be doing a talk today, or roundtable on VV-ECMO, which Furf, I know this is one of your favorite topics. So I know you've been raring to go for this for a few weeks now.
Yeah, absolutely. Obviously, I loved thinking about this. I love talking about it. I've worked with a lot of the people on this call and seen them at the national conferences and really wanted to do this episode. And I'm excited to sort of just dive into everything. So let's meet our guests for this roundtable and we'll kick it off.
Perfect. And, we're joined by three amazing guests that are known in the field. And I'll start first with the honor of introducing Dr. Kara Agerstrand. Kara is an associate professor of medicine at Columbia University Irving Medical Center, New York Presbyterian Hospital, where she's also the director of the medical ECMO program. She's an internationally renowned ECMO expert and is the current conference chair for the Extracorporeal Life Support Organization, or ELSO. Finally, she's a lauded educator and has received the American College of Chest Physicians Distinguished Educator Award, which is awesome in and of itself. And Kara, we couldn't be happier for you to join us today. Welcome to Pulm Peeps.
Thanks so much. I'm happy to be here.
Our next guest is Eddie Fan. Eddie is an associate professor at the University of Toronto and the University Health Network Mount Sinai Hospital. He's also the director of critical care research and the medical director of the Extracorporeal Life Support Program. He has literally hundreds of publications about ARDS, ECMO, and critical care. He chairs the ELSO Research Committee, and he spearheads multiple international collaborative studies. And having been at ELSO recently, people swarm around Eddie just to get a little bit of time talking to him about ECMO. So we're really thrilled to have an hour to talk to you today. Thanks so much for coming on the show.
Well, thanks, David, for that very kind introduction. I'm really pleased to be here. So thanks for the invitation.
Welcome, Eddie. And last but not least, I have the pleasure of introducing Dr. Nita Kadir. Nita is an associate professor at the University of California, Los Angeles. So she's, I think, joining us from Pacific time today, so appreciate that. And she's also the associate director of the medical intensive care unit there, as well as the co-director of the post-ICU recovery clinic. Nita is also on the critical care editorial board for CHEST and is a highly regarded pulmonary critical care educator. And I think she seems to be as addicted to Twitter as many of us. So I think we're all in good company. And Nita, we couldn't be happier for you to join us as well. So welcome to Pulm Peeps.
Thanks so much for having me. I'm honored to be in such lofty company and really looking forward to this discussion.
Just for a reminder, this podcast is for educational purposes. None of the advice should be applied to specific medical cases without the details. And the views of all of us may not necessarily reflect the views of our respective employers. All right, so let's dive in. We want to tackle big topics on Pulm Peeps, but in doing so, we know it's a bit of a daunting task to try to cover everything. So certainly we won't be able to talk about everything about VV-ECMO, but we do want to give some basics and then a launching off point to talk about some key topics of discussion. So in keeping with that, let's quickly talk about some of the basics. So Eddie, lofty task, but in broad strokes, could you just tell us what is VV-ECMO and how it sort of fundamentally works?
Sure. So as the name implies, VV-ECMO, it stands for veno-venous extracorporeal membrane oxygenation. And here the VV tells you where the blood is being drained from and where it's being reinfused. And so the idea here is, broadly speaking, is that, as the name implies, blood is drained from a large central vein, typically, say, the femoral vein. And that's sent in modern ECMO devices by typically a centrifugal pump to an artificial membrane lung. And there it functions like our native lung. It adds oxygen and it removes carbon dioxide. And then that arterialized blood is then returned, as the name implies, to a large central vein, let's say the internal jugular vein. And this system is connected in series, if you will, with the native cardiopulmonary circulation and provides really only respiratory support. And so you see that if the arterialized blood passes through the internal jugular vein, it then goes to the right heart. Your right heart has to be functioning to pump that into the pulmonary circulation. Then it enters the left heart. Your left heart has to be working to pump it into the systemic circulation, where that oxygenated blood can then do its business. So here the heart has to be working, and VV-ECMO is ostensibly just providing respiratory support. The other final maybe point in broad strokes to think about is the real nice thing about ECMO is that oxygenation and ventilation or carbon dioxide removal is relatively dissociated, right? So we can manipulate oxygenation by increasing or reducing blood flow rate, so how much is being drained and being returned to the body, and that's typically thought of as a function of the person's native cardiac output. And ventilation or CO2 removal is controlled by the sweep gas flow rate. So the more sweep gas that we put into the artificial lung, the more CO2 is removed, and the less sweep gas flow we put in, the less CO2 is removed. So that's sort of broadly speaking the basics of VV-ECMO.
Yeah, thanks so much. Great, succinct explanation. Now that we sort of understand that this is an extracorporeal option, oxygen in, CO2 out, we can control them independently, and that we're relying on the native heart, we should sort of think about who are the patients that this is going to help us with. So, Kara, I'd love to turn to you for that. Broadly, which patients are being supported on VV-ECMO? Like, what are the major indications that are getting us to this conversation?
Great. Yeah, that's a great question, Dave. So the majority of patients treated with VV-ECMO today have what we call ARDS, or the acute respiratory distress syndrome, patients with acute, reversible, and severe respiratory failure, often caused by pneumonia. We typically will support those patients for anywhere from 1 to 2 or 3 weeks at a time until they can sufficiently recover, given time, antibiotics, and other treatments. Other conditions that VV-ECMO would be used for include status asthmaticus, so severe forms of hypercapnic respiratory failure, and also as a bridge to a lung transplant. This is typically in patients with cystic fibrosis, maybe in patients with interstitial lung disease who don't have concomitant pulmonary hypertension or other severe advanced forms of chronic lung disease.
Thanks so much, Kara. And it sounds like for these patients that you mentioned and the populations, we're really trying to use VV-ECMO as a bridge to either get them to transplant or to help them while we treat their underlying lung disease or specific infectious etiology. Anita, I wanted to turn to you and ask you a little bit more. I know Eddie highlighted some of this when he was describing the general point of VV-ECMO, but wanted to get your sense on some more specific goals with ECMO to achieve endpoints. And specifically, when you're caring for a patient on ECMO, what are your oxygenation and CO2 removal goals?
So in terms of oxygenation and CO2 removal targets, the specific numbers are not necessarily very well defined or even agreed upon. But I want to talk a little bit more about the overarching goals for oxygenation and CO2 removal. And basically the big picture, your major goal is to have gas exchange supported by the ECMO circuit and not the lungs. And by doing that, you can put the patient on lung rest vent settings, which we'll talk a little bit more about later on in this discussion. In terms of oxygenation and CO2 removal, oxygenation is the more challenging thing to accomplish. So I think it's important to understand the variables that determine how well you can oxygenate a patient. And Eddie touched on this a bit already. But just to expand, those variables are the FiO2, the ECMO blood flow, and the ratio of the ECMO blood flow to the patient's cardiac output. And while the first two variables, the FiO2 and ECMO blood flow, are intuitive and I think well known, the ratio of the ECMO blood flow to the patient's cardiac output is something that I think is less talked about, but also really does make sense intuitively. Not all of the patient's venous return is instantaneously going to go through the circuit. So even though the blood that's returned to the patient is fully oxygenated, it's mixing with the rest of the patient's venous return, where the oxygenation is, of course, going to be much less. So with your initial ECMO settings, you do want to keep this in mind when you're setting the flow. It's going to be different for, say, like a 5'2" woman with IPF who is pre-lung transplant than it would be for, say, a 6'2", 100-kilo man with strep pneumonia, sepsis. CO2 removal, on the other hand, is much easier to accomplish as the CO2 basically readily diffuses across the membrane. And the CO2 removal is largely determined by the sweep gas inflow rate. It's a very effective process, and this is important to keep in mind if you have a profoundly hypercapnic patient. You might actually want to start at a lower sweep flow rate to ensure that you have slow, controlled CO2 removal to minimize the risk of neurologic injury.
Thanks so much for walking us through that. It's always helpful to think about when we're trying to achieve these goals of what we're aiming at, but then also how easy it is and sort of what factors on the ECMO circuit are helping us achieve them. Follow up on a couple other things we think about with these patients. I know caring for ECMO patients is really complex. We're obviously going to be looking to provide the adequate oxygenation and CO2 removal that they need. But, I was hoping you could expand too on some other factors we're sort of monitoring to know if our patient is getting better and things that we're aiming for on ECMO. You mentioned things like lung protection, but trying to see what types of things we're trying to achieve with the circuit to help our patients along in their recovery process.
So in terms of what we're trying to achieve, I think a lot of critical care amounts to supporting the patient while avoiding complications and giving time for healing. And I think the same concept applies here when it comes to the ventilator. So we mentioned long rest ventilator settings, but basically, since you're no longer fully dependent on the ventilator for oxygenation, you can put the patient on vent settings that are much less injurious and reduce the risk of ventilator-induced lung injury.
Great. Thanks so much, Nita. And I feel like we've gotten a sense of, how ECMO works and some of its uses and target populations. And it seems like, for the right patient, it could be a really powerful tool. But I think like in everything in medicine, there's sometimes things that it's helpful for, but we also have to be cognizant of some of the downsides as well. So Eddie, I wanted to ask you, what are some of the major risks that you see for individual being on VV-ECMO?
Yeah, this is a good question. I think, broadly speaking, probably the major risks we typically think about when we think about ECMO are bleeding and thrombosis. There are going to be a whole host of risks that are also associated with the fact that, like any vascular access device, there could be vascular injury at the time of cannulation, bleeding, infection risk, these sorts of things, which are certainly important and to think about in the ECMO patient. But really, when we think about ECMO, we're thinking about the risk of bleeding and thrombosis. We have good studies suggesting that bleeding is more common than thrombosis, and bleeding is more important from a prognostic point of view than thrombosis. And I think bleeding is really the main risk that clinicians think about in the trade-off of what the benefits could be with VV-ECMO versus the downsides. And that bleeding risk comes from, again, broadly speaking, two factors. One is that the artificial membrane lung and the pump can induce coagulopathy and platelet dysfunction in and of itself. So, that's one factor. And second is that typically we run these systems with some form of systemic anticoagulation to prevent thrombosis of the artificial membrane lung and circuit. And so these two things together, coupled with whatever underlying critical illness the patient might have, leads to typically a confluence of higher risk for bleeding. And so this could be, again, bleeding at the vascular access site, bleeding from other vascular access sites, could lead to GI bleeding, other mucosal bleeding. And really the critical one that we think about as clinicians is intracranial hemorrhage, which is, in the sort of 5 to 10% range if you look at data from the ELSO registry, but certainly it could be catastrophic if it occurs and is often fatal in these patients. Thrombosis is less of a concern. So it could be thrombosis of the circuit itself or the membrane, and that can lead to dysfunction, which has its own host of problems. But also, as the cannulas stay in the patient for a much longer period of time, if there's some enforced bed rest or immobilization, then they can get both cannula-related thrombosis or, other sort of thrombotic events from being immobilized in bed. But again, bleeding, I would say, is the major risk that we think about when we're thinking about VV-ECMO.
Great, thanks, Hetty. So yeah, bleeding and thrombosis, I think those two things we can definitely remember. And, I think definitely thinking about someone, who may be thrombocytopenic and for the reasons you said may not be anticoagulated, could be someone that or may not be able to undergo VV-ECMO. Kara, I wanted to ask you though, what are some other contraindications to VV-ECMO and certain patient populations that aren't good candidates?
Yeah, that's a really important question as well. It's funny because as complex and as high resource of an intervention that ECMO is, there aren't a lot of absolute contraindications, but there are many relative contraindications. So I would say probably the only absolute contraindication is, a patient who has advanced disease, organ failure, or an inability to recover, even if ECMO were to be initiated. For example, someone who has catastrophic brain injury, prior to consideration of ECMO, or prolonged cardiac arrest without neurologic recovery, or advanced lung disease without the option for transplantation. Those patients are unfortunately not going to recover whether or not VV-ECMO is initiated, and in that would be an absolute contraindication. There are a lot of relative contraindications and certainly things to be considered in the calculus of whether someone is, as we say, an ECMO candidate. For ARDS, probably most importantly, that would be prolonged respiratory failure. So a prolonged period of time receiving high pressure ventilation, high FiO2, where we think maybe some of that damage has already been done, to those lungs. Other relative contraindications would be things like active bleeding, problems with vascular access, for example, or other comorbidities that may make recovery more challenging. For example, a patient with some degree of liver cirrhosis and decompensated liver disease, as an example. In patients going to lung transplant, the contraindications really are center dependent, but some factors that would be considered might be the patient's transplantability. What is their likelihood of getting lungs? What is their lung allocation score? What is their PRA? Do they have a high antibody positive panel that may make finding a lung match more difficult? All these things are considerations in whether or not a patient will be cannulated.
Thanks, Kara. And I really like your framework that a lot of it is relative and sort of thinking broadly about who's going to benefit. I feel like this happens so much that there's this list of you can't be on ECMO if you have these things, but we've probably all seen someone on ECMO with one of those things, right? So it's, can they get better? And we're sort of making a judgment call about that as a group. From there, I want to dive in a little bit more on some specific topics and really spend some time on VV-ECMO and ARDS. I think, as you said, Kara, this is the most common indication for ECMO. Certainly with COVID in the last couple of years, it's led to sort of an explosion of this being used, and an explosion out in the media and social media and things like that. So I'd love to chat about ARDS as an indication for ECMO. And I feel like any discussion with this at this point ends up touching on or starting with the 2018 EOLIA trial. So to remind our listeners or inform them, this is a randomized controlled trial of patients with severe ARDS, randomized to VV-ECMO or conventional care. That conventional care was very well defined and adhered to as the ARDS-NET protocol standards. The trial was stopped early for futility, but the primary endpoint was looking at 60-day mortality, and there seemed to be no difference between these two arms. However, there was a trend towards benefit with ECMO, and there was a significant amount of crossover from the conventional group to the ECMO group in this trial. And importantly, safety points were similar between the two groups. So I've heard this trial described by many people as a rationale for ECMO as a rescue technique. I've also heard of it described as just confirming opinions on both sides. Someone once told me it was the most positive negative trial they'd ever seen, right? So a lot of different opinions about it, and I think it's important to delve into them. Nita, can you tell us how you interpret the results of the EOLIA trial and how it leads to influencing your practice?
Sure. Well, before I tell you my interpretation, I want to point out a few other things about the trial that might explain my interpretation.
Please.
So, one major strength of EOLIA, as you mentioned, was that unlike the older Caesar trial, this group really did assess the impact of ECMO as an intervention versus just being at an ECMO center. So they used a protocolized vent strategy, and there's also a high rate of use of other adjunctive therapies. And I think this is really important. After randomization, I believe about 90% of the patients getting conventional therapy got prone, and about 2/3 of the ECMO group did as well. And so why does this matter? Well, usually evidence-based practices are way underutilized. In one large US ARDS cohort pre-COVID, prone positioning was only used in 11% of patients who ultimately got ECMO. So before EOLIA, I often just wondered if a lot of times we would just not need ECMO if we were actually managing ARDS appropriately. And this trial addressed that exact concern by ensuring that best practices were used in the control group. And they found that mortality was still lower in the ECMO group. The fact that this mortality difference was not statistically significant. Well, I think there's some caveats to that too. So the trial unfortunately ended up being underpowered. The investigators had expected a mortality rate of 60% in the control group, 40% in the ECMO group. And, expecting an absolute difference of 20% was probably pretty ambitious. And unfortunately, the trial was stopped early due to their predefined stopping criteria that said to stop if they were unlikely to attain a definitive result. So, at the end of the day, is there an absolute risk reduction of 20%? Probably not, but there probably is a difference that is lower in magnitude. And in fact, there was a follow-up article in JAMA that used a Bayesian approach to look at the totality of ECMO data at the time and found that this indeed was the case. So my interpretation of EOLIA is that ECMO does likely lower mortality compared to current best practices, but it's unclear how large that benefit is. And, unfortunately, without knowing the magnitude of benefit, it's still really hard to answer the question of whether we should use ECMO as a standard therapy for severe ARDS or just as a rescue for those we can't oxygenate with usual care. And an intervention like ECMO, it's not, say, like IV vitamin C, which I don't know, maybe should never be mentioned again. It's like, it's costly.
No, for sure.
It's costly, it's resource intensive, it's invasive. So you really have to think about what is the minimum clinically important difference to make it worth implementing ECMO as a standard therapy. So I guess that's a lot of words to say that, yes, I think EOLIA shows us that ECMO improves outcomes in severe ARDS, but I am still unsure if it helps enough to change its status from a rescue therapy to a routine therapy for severe ARDS.
Thank you, Nita, and specifically for adding in some of the additional context to the original study. I think that's helpful for us to remember. And I know in addition to EOLIA, and you mentioned CSER trial as well, there's a lot of reviews and meta-analysis that have been done. And I feel like, I remember a couple of years ago, we had a pro-con debate for one of our fellows lectures, and it's just so interesting people bring these up, but for both trials, but for the reasons you said, people are still kind of hard-pressed to make final decisions on that. So Eddie, I think I'm going to probably ask you a challenging question as well. Just, how do you interpret the cumulative data that has been published so far? And overall, do you think there's a role for ECMO in ARDS?
Yeah, thanks. I think it is a bit of a challenging question, but I think more clarity has been forthcoming from these studies, and I think Nita's already touched on all the important points here. But so the original trial, as Nita eloquently summarized, did show an 11% absolute difference in mortality in favor of the ECMO group, even though that was not statistically significant, and most of the secondary outcomes were all in the direction of favoring ECMO. So although not significant, it suggested a signal for ECMO, although the magnitude, we're not sure how big or small. And because, that this trial was very difficult to complete and took a long time, what we have are these secondary analyses. And so Nita's already mentioned a Bayesian reanalysis that showed across a range of priors from very skeptical to very optimistic or enthusiastic, that even amongst the very skeptical, there was an 89% chance that ECMO is going to be beneficial in these patients. And then now we have a host of, as you already mentioned, Christina, we have an individual patient data meta-analysis from the CSER and EOLIA trial. We have a number of study-level meta-analyses, and we even have 3 network meta-analyses looking at a web of interventions, many of which, again, Nita's touched on: prone positioning, inhaled pulmonary vasodilators, lung protective ventilation, recruitment maneuvers, and ECMO, where all the totality of these syntheses all suggest a benefit for VV-ECMO in severe ARDS patients. So my take on this is that we're unfortunately unlikely to have a larger, more definitive randomized controlled trial in the future. So these are the best data that clinicians at the bedside have to make a decision on whether to use ECMO or not. And my interpretation of all the primary and synthesized data is that, yes, there is a benefit in severe ARDS from the use of ECMO, although the magnitude of that benefit, as Nita mentioned, is not clear. And again, so we should be considering, as we do for any intervention, like what the trade-offs could be in that individual patient for what we think the benefit could be versus what the downsides might be for that patient. And I think, again, and to end, is that this has already been somewhat codified in the forthcoming ESICM clinical practice guidelines that recommend or suggest the use of ECMO in severe ARDS patients, and is being evaluated in other guidelines that will be forthcoming from other professional societies.
Oh, fantastic, Eddie. Thank you so much. And I think from what we're saying so far, if someone was just tuning in right now, it seems like based off the studies that we have, ECMO may be appropriate and beneficial, but the magnitude is still yet to be determined with that. But as you said, Eddie, some ECMO can be a useful tool for patients with severe ARDS. Anita, I just wanted to ask you, what specific things are you looking for in a patient or in someone that you think is appropriate to be referred for VV-ECMO?
Yeah, and I don't know about you guys, because I'm glad you're asking, because this is I feel like the question I get the most from residents, which patients? I mean, I take care of a lot of ARDS. When should I be calling you guys, and when are you interested in hearing about them? So, Nita, I'd love to hear your take.
Yeah, I think this is a really important question and something that every intensivist should know, whether you're at an ECMO center or not. So criteria are unfortunately highly variable at different institutions. But here at UCLA, we consider ECMO in patients with a P to F of less than 80 or a pH less than 725 due to hypercapnia in spite of optimal medical management. And that's in line with what ELSO recommends as well. So the optimal medical management is important. We define that as appropriate vent settings with a trial of proning and neuromuscular blockade. Proning, there is, of course, a substantial amount of evidence to support that. Neuromuscular blockade may be more debatable, but it's certainly worth trying a less invasive therapy before a more invasive therapy. So that's our rationale. Again, this is all really important, and I really want to emphasize the optimal medical management part, because I can't tell you how many times I've been called for ECMO, and then 2 hours later, the patient's PEEP is increased and they're proned, and they're down from 90% FiO2 to 50% FiO2. Other important things are that the patient has a reversible cause of ARDS, because if not, there will be no endpoint to ECMO, and that it's relatively early in the patient's course, meaning ideally they've been intubated for less than a week, and ideally the earlier the better. At our center, our average duration of mechanical ventilation prior to ECMO is actually just 2 days, which is definitely enough time to optimize ventilator management and prone someone. And early is important because one of the benefits of ECMO, again, is the ability to utilize long rest settings and minimize ventilator-induced lung injury. If someone's been intubated for 10 days already, they've likely already experienced a good amount of ventilator-induced lung injury. And also, just circling back to EOLIA a little bit, we saw that patients who crossed over from conventional therapy to ECMO, meaning got ECMO late, had pretty terrible outcomes with mortality approaching 60%. We also assess for contraindications to ECMO, some of which have been mentioned already, or other factors that might be associated with a worse outcome. Again, a lot of which Kara mentioned earlier.
Thanks so much. I love the point that you're emphasizing about the optimal medical care and good vent settings. I think talking to the residents recently was saying how, they were asking if there are people like ECMO zealots and sort of what they believe. And I was like, well, one thing is that anyone who's an ECMO zealot is a proning zealot, right? You have to do sort of the optimal medical care. We would all want people to get better without an invasive option and to have one if we need it. After that, after we've evaluated them and thought that they were a good candidate, I'd love to hear from all of you, from your centers that have a lot of high volume. Once ECMO is considered, how does that process work? How does the evaluation go from there? So maybe, Kara, we can start with you, and then Eddie and Nita, if there's something different or additional that you guys do, I'd love to hear what those things are.
Yeah, absolutely. So for us at Columbia, the way it works is all ECMO referrals from external hospitals come through our hospital-wide transfer center. Those calls are funneled specifically to one of our ICUs, where our ECMO NP will take a clinical history of that patient. We actually have developed an automated part of the EMR intake system to make sure that we ask all the critical questions we care about. Why does this patient have ARDS? If we know how long have they been intubated, other relevant issues in their history, laboratory findings, etc. Then we'll convene a multidisciplinary team of providers, including both our medical and surgical members of the ECMO team, to sort of determine that patient's candidacy. If that patient's a candidate, we'll depart immediately or as soon as we possibly can to pick up that patient, cannulate them at the referring hospital, and then bring them back to our ICU. That's the way that most of these consults work. And, I think it's important for centers, who are calling or thinking about referring a patient to really not delay once you have a patient that meets criteria, or once you have a patient even that you think is going to meet criteria, once, optimal other standard of care medical therapies and treatments, as Nita mentioned, prone positioning in particular, have been employed.
Yeah, that's great, Kara. And it's so awesome to hear about how it works at different places. Like where I am now at BI, the same sort of referral, although they're not cannulated in the field. They're brought over and making sure that I'm optimized at our center and then done it. And it's just, different ways that they function. Eddie and Nita, I don't know if your guys is similar or if you're doing mobile ECMO or in the field cannulations.
We did a lot of mobile ECMO prior to COVID-19. So about a third of our ECMO referrals were for mobile, like cannulation and then retrieval. COVID really put made it difficult to send our human health resources for so many hours to assess that. So we did a lot more of the transfer, stabilization, and if needed, cannulation at our sites, and took referrals much earlier during the COVID-19 pandemic, just because of the strain on our system. I think otherwise it sounds like our system is quite similar to what Kara described. I think the only other point I might mention is that I'm sure, like in both Nita and Kara's hospitals, the decision is interprofessional and multidisciplinary. So we don't typically make any decisions on candidacy or timing or these sorts of things like in isolation. So it doesn't happen to be the NP or the physician or whoever's on call who gets the call. We usually collect that information and discuss it as a team. And at least in my hospital, that requires at least two physicians, usually a surgeon and an intensivist, or two intensivists or two surgeons, depending on who's available. And we can always bring in more ECMO team members if there's not a clear consensus or there's some concerns or red flags that we want to flesh out more, discuss more. Because again, I think as Nita mentioned, it's a very resource intensive, invasive, and costly intervention. And we want to be sure that we're deploying it in patients that we believe will benefit from the therapy.
So at our center, the process is pretty similar to what both Kara and Eddie described. A multidisciplinary team discusses the patient's candidacy. We do mobile ECMO, and I think actually a majority of our patients who go on ECMO have originated their care at an outside hospital. I'm glad that Eddie brought up strain, because a part of our multidisciplinary discussion includes a discussion of resource availability. So like bed control and nursing leadership are on those calls. And, this is maybe uncomfortable to talk about, but I think important to bring up. During times of strain, our ability to take less than optimal cases decreases. That's uncomfortable for everyone, but unfortunately a reality that we saw a lot of during COVID, but even, during the worst of COVID, but even beyond that. So, for example, say you had like a previously healthy 65-year-old with influenza and ARDS who had been intubated for 10 days. That might be someone I cannulate if I have plenty of bed availability, but someone I, might not be able to take a chance on if we are under strain and, we have to like perform bed gymnastics to make a bed available.
Yeah, thank you for pointing out. I think these real world problems really became highlighted during COVID, and it will be things that we should ongoing discuss and plan. And the dialogue is important, right? So if it happens in real life, we should be talking about it. So thanks for bringing it up. I think this next question is the one I'm most looking forward to, because I feel like there's the least sort of guidelines on this, and it's a question I get all the time. So Nita mentioned the importance of using ECMO for ultra lung protective ventilation, trying to say that we don't need to use the ventilator as much. We know the ventilator, while often necessary, can be harmful to patients. And so we want to put patients on lung rest or lung safe settings. Kara, I'm going to sort of start with you. I know you were on this lifeguard study where the whole purpose was to try to figure out what people are doing with ultra lung protective ventilation and what helps. And I know one of the takeaways is that most ECMO centers are doing some version of this. So what does ultra lung protective ventilation look like? How should we be ventilating these patients once we have them on the ECMO circuit for ARDS?
That's a really fantastic question, Dave. And I think when people ask, what is lung protective ventilation, it's kind of asking like, what is love? It's different things to different people. But the overall principle is really that what we want to do with ultra lung protective or, lung rest ventilation is shift the work of breathing. I say that in quotes from or gas exchange from the patient to the circuit. Right? So we want to use the circuit for that exchange of oxygen and carbon dioxide and really minimize the need for the patient's lungs to do so. This is, as we've discussed, with the goal of preventing further ventilator-induced lung injury. And what that looks like practically is really reducing the mechanical power to the lungs, right? So we're reducing both the respiratory rate and the pressure applied to the lungs, sort of broadly speaking. We might have that patient's respiratory rate set at, let's say, 6 to 10 breaths per minute. We will try to minimize that pressure on the lungs. For example, going from a high peak maybe of 15 or 20 down to a moderate peak of 10. Weaning the FiO2 on the ventilator as much as possible. Minimizing the tidal volumes, perhaps targeting a plateau pressure, certainly less than 24 or 24 and under, as they did in EOLIA, or potentially lower, either via volume control or pressure control mode of ventilation. Different centers have different approaches to lung rest. Some people prefer volume control, some people prefer pressure control, some people prefer like a modified APRV type setting. But the idea overall is really similar throughout the world, which is reduce that mechanical power to the lungs themselves.
That's great. Eddie, Nita, anything to add?
Nothing other than the what is lung rest being equivalent to the what is love question is pretty great. And I'm going to steal that.
I agree. That might be the title of this episode.
When you guys find the answer, please let me know.
Yeah.
Totally.
I was going to say the same thing, Nita, and I'm gonna connect the two of those each time I think about them now. And I know we've spent a lot of time talking about ECMO for ARDS specifically, and we'll try to end, on one kind of general question, which can still be daunting and challenging to ask, but it's regarding the future of VV-ECMO for ARDS. And Eddie, I know you mentioned earlier, the studies that we have right now are the best data that we can use to help guide our care of patients. But if you could, I guess, envision or, in your perfect world, I'll start with you, Eddie, what will the next trials look like that can help guide our care for VV-ECMO in patients?
Yeah, I think if you start from the premise that VV-ECMO is useful in patients with severe ARDS, then I think future studies to help us understand how to improve the benefits or maximize benefits and reduce risks or complications might be the way forward. So some ideas on that might be, for instance, the risks, like how can we reduce bleeding and anticoagulation requirements? That might be better surfaces, better coatings, more optimal anticoagulation strategies. We've talked a lot about mechanical ventilation. We think that's an important component. So how to optimally mechanically ventilate these patients might lead to more benefits and less risks. How do we mobilize these patients? I think we're going to talk a bit more, so reducing morbidity and not just improving morbidity and not just improving short-term outcomes. So I think a lot of these things, sort of the management around ECMO patients, which could help sort of tip the scales in favor of greater benefits and less risks or complications, might be the way forward for the future. And the second important thing I think that we learned from COVID, or one of the many things we learned from COVID, is that could VV-ECMO actually be beneficial in patients who are less hypoxemic than our current threshold, for instance, from EOLIA of a PaO2 FiO2 ratio of 80. So interestingly, a number of more rigorous observational studies in COVID, including the Stop COVID investigators and one from the COVID-19 Critical Care Consortium, suggested that VV-ECMO was beneficial in patients who had more moderate ARDS, up to a PF ratio of maybe 150. So perhaps a future study could look at whether VV-ECMO indeed is beneficial in patients with less severe hypoxemia.
I love that, Eddie. Nita, Kara, anything else that you want to add that y'all are thinking about?
I would just add to anybody who's listening to the podcast is that not every center is an ECMO center, and probably not every center needs to be an ECMO center, but it's so critical for all of us in the critical care community to know where to refer our patients who might be ECMO candidates. So to establish those relationships with maybe a larger regional hospital or tertiary care hospital, in relative geographic proximity, to have a known, sort of pipeline as a place to sort of to refer and send, those patients who might benefit from this device.
I would agree with that. So, even beyond a research standpoint, from an operational standpoint, because not all centers are ECMO centers, I think and hope that there will be efforts to regionalize ECMO. Unsurprisingly, outcomes are better at places that do a high volume of ECMO. And in an ideal world, I would think that there would be networks of hospitals within a region that would be affiliated with an ECMO center with a mobile ECMO team. From a research standpoint, Eddie touched on a lot of unanswered questions that we have about minimizing risk for patients once they're on ECMO. And I think there's so much material there, because a lot of how we manage these patients currently is based on expert opinion rather than robust data. So, a lot of very basic questions like, what are the right oxygenation targets, or how are drug pharmacokinetics impacted by ECMO? Those are all areas that we need to delve into further.
Awesome. So I want to turn the conversation now to ECMO, away from ARDS, but as a bridge to lung transplant. Kara mentioned this as one of the uses, and I think it's a nice lens to talk about some other topics in ECMO as well. Based on the current transplant data, at least from the United States, the amount of ECMO as a bridge transplant has increased pretty dramatically in the last few years, while mechanical ventilation as a bridge is decreasing, sort of showing that there's maybe a favoring of using ECMO in some patients if they are the right candidates. I was just wondering if you could opine a little bit about why this option is increasing in popularity in the transplant world.
So I think a couple of reasons. One, there are more places using ECMO, and there's an increased level of comfort with ECMO. And I think, more than that, though, unlike patients with ARDS, patients who are started on ECMO pre-transplant generally do not need to concurrently be on mechanical ventilation. And because of this, using ECMO as a bridge to transplant rather than mechanical ventilation as a bridge to transplant allows patients to maintain their mobility, be awake, participate in rehab, which we all know is crucial pre-transplant. So I think that's probably the biggest reason why why enthusiasm for ECMO as a bridge to transplant has increased.
A big part of transplant is staying, physically fit, as been mentioned previously. And I know that sometimes patients bridging to transplant on ECMO are not intubated. And Kara, I wanted to see what you thought some of the challenges of managing a patient who is not intubated but who's on ECMO could be that our learners should be aware of.
Yes, I think in general, having these patients non-intubated, not trached or whatnot as they bridge to transplant is typically the way we tend to go, and it works quite well. I think some of the challenges to look out for are that when you have an awake patient, you have the issues that come with a patient in the ICU being awake, which might be that they're very anxious or nervous. Maybe they might become delirious at night and pull at things, and it's one thing when someone pulls out their IV, but it's certainly another if they want to pull out that cannula. So we certainly need to be very mindful of those, ICU-related patient issues that can arise. I think, kind of from a broader perspective, one particularly difficult challenge in an awake patient who's bridging the transplant is what happens if that patient no longer becomes a transplant candidate. Let's say for whatever reason, maybe they've developed, drug-resistant infections that, they can't clear or whatnot. And now you have a patient who's been delisted from that transplant list, who is awake, interactive, and is, sort of has no destination, right? This bridge to transplant has become this, bridge to nowhere, so to speak. So that would be, potentially very challenging for the patient themselves, for the patient's family member, and for the entire ICU team who now are struggling with caring for a patient who doesn't have, real viable outcome.
Yeah, totally. I was reading a great piece recently about how the advent of mechanical ventilation was like a door for a lot of the ethical issues we talk about now, like brain death and things like that didn't happen as much. And I think you're touching on it right, is that, with any new technology, there's going to be some ethical things that come up at some point. And so worth thinking about. On the same topic of the bridging them to transplant and not having them intubated, I want to talk a little bit about mobility. And this is not just for bridging to transplant patients. I think we're hoping to talk about this in patients who are recovering also, but it's a pretty intimidating concept about mobilizing people who are on ECMO. And I feel like once, there's a lot of videos out there of people playing basketball and walking that, are always very impressive. So Eddie, I just wanted to ask you, in your unit, how are you safely mobilizing patients? If they're intubated, if they're not intubated, what kind of things are necessary for that?
Yeah, I think it's a good question, Dave. And I think maybe to start with exactly that, dispelling the idea that the vast majority of ECMO patients are playing basketball or out in the courtyard of the hospital enjoying the sunshine. I think, at the present time, it's still a relative minority of patients. And I would say of that minority, the majority of those patients are typically the patients like Kara described. They're non-intubated, bridging to lung transplant. It's much easier to manage these patients who have a more chronic respiratory failure picture, awake, mobile, cooperative on ECMO than it is sort of an acutely, more critically ill patient with ARDS, influenza. They're highly inflamed. They might have other organ dysfunction and that sort of thing. But like in non-ECMO patients, we're trying always to target light levels of sedation, get our patients awake, liberate them from life support when available, and if safe to do so, to have them undergo early mobility, which may be a gradient from passive, bed exercises all the way up to ambulation if possible. I think when thinking specifically about ECMO, it's the key thing is much like in the awake patient is we don't want the patient to become more unstable when you try to have them undergo some kind of rehabilitation. And two is to maintain security of the cannula that are in place, because if that goes badly, then things will go very badly. So in terms of the first one, we have sort of, again, it's an interprofessional team. We have very experienced physical therapists in my unit who've been mobilizing transplant patients, ventilated patients, and now ECMO patients. And we do a kind of timeout like you would for any procedure. What is the therapy plan that the physical therapist is planning today? Is it just pivoting to a stand? Is it just dangling at the bedside? Is it actually marching on the spot? These sorts of things. And then we have all the necessary support staff there. So typically the bedside nurse, a perfusionist to modulate the perfusion settings if the patient's intubated, perhaps also a respiratory therapist to modulate mechanical ventilation. And then once we have that plan in place, then we try to make adjustments that might be needed to help ensure stability when the patient undergoes that physical therapy. So again, like you would in a ventilated patient, you might want to increase the level of support. You might want to increase the FiO2 because they're about to undergo exercise. So we might similarly increase or modulate blood flow. We might increase sweep gas flow rate to make the patient more comfortable and tolerate therapy better in these situations. And before we mobilize patients to sitting at edge of bed or higher, we always have the cannulator, which is typically in my hospital, the surgeon, come every morning to assess the cannulation sites, that the sutures are all in place, the cannula is well secured. We actually make daily measurements of where the cannula is to make sure that it hasn't shifted. So the cannulation team signs off that the cannula is secure for the proposed therapy that's about to happen in that day. And so with those pieces in place, we safely mobilize patients on ECMO and fortunately have not had many serious adverse events from these sorts of interventions.
Very cool.
Thanks so much, Eddie, and definitely a team approach for mobilization. And I think we are exactly at an hour on the dot, and I can't believe how fast the time has flown by together during our conversation. I think we got a lot of great and insightful tips from the three of you, so definitely appreciate you all. What Furf and I like to do kind of at each episode is just leave the listeners with some final takeaways. So kind of one or two key points that you want listeners to remember. And I can go ahead and start. And I think I have three, one kind of from each of you. I think from Nita, you were saying based off the studies we have so far, while the magnitude is still not known, and future studies can help address that, ECMO can be appropriate in certain patient populations in severe ARDS. Eddie, I remember you saying the risks that we should be mindful of include both bleeding and/or thrombosis. And Kara, I think from you were saying there's, besides an irreversible kind of condition and not a patient not having a bridge to another outcome, that may be an absolute contraindication, but otherwise there's just more relative contraindications for ECMO. And I think we're all going to remember and parallel long protective rest and love going forward after this. But Burp, I'll go to you next. Any takeaways you want people to remember?
Yeah. I'm just going to go for an early one. Eddie was describing the circuit and he talked about it being in series with the patient's cardiopulmonary system. And I just think it's really important when you're learning this to have a core sense of the physiology and understanding that you're really doing something that then is dependent on their own heart, flowing through their own lungs and going out to the body. So a good, simple framework for people to remember.
Perfect. Nita, what about you?
So in terms of takeaways, I think every intensivist, as I mentioned before, whether you're at an ECMO center or not, should know when to refer for ECMO. So the answer to that is refer as early as possible, but not before you've optimized the vent and prone the patient.
Perfect. Kara?
I would definitely agree with Nita on that front. That's really the critical, I think, takeaway. I mean, it's one thing, to put a patient on ECMO, but so much of success really relies on the medical management of that patient after cannulation and that sort of multidisciplinary interprofessional team approach to the care of these very complex patients.
Fantastic. And Eddie, what about you?
Yeah, not much to add to what everybody said. I think based on the current evidence, I think it's gone beyond not it's not a question of if ECMO works, but when and in whom. And you've heard sort of in this podcast, sort of the considerations for those. So that might be the advice I leave with listeners.
Awesome. Well, thank you again to our three amazing guests. Thank you all for tuning in and listening. We'll have more episodes coming up soon and hopefully some more detailed things about ECMO, ARDS, and proning and all the topics we've talked about. This episode was written and produced by myself and Christina Montemayor. The music's original music by Eric Rogers, and we'll see you next time.